Hello, everyone, and welcome to our fourth Fireside Chat presented by IgG4ward. I am Katharine Provencher, and I am the Director of Patient Advocacy for the Foundation. I am truly honored to be here sharing the screen with Dr. John Stone, the Executive Director of the Foundation and also the founder. We are so excited to have a wonderful list of questions submitted by you, the community, that we will be answering to the best of our ability today. I am going to be passing this off to Dr. Stone so he can read the mission statement for us.
Thank you, Katharine. So at IgG4ward, our mission is to improve the lives of people living with IgG4-related disease through education, expanding disease awareness globally, facilitating groundbreaking research, and being the trusted source of truth for IgG4-related disease patients, caregivers, and healthcare providers.
Thank you, Dr. Stone. We also have some very exciting announcements to share with you all today. In June 20th of 2024, we will have another fireside chat, and that chat will be hosted by Matthias Löhr and Guy Katz, and the focus of that fireside chat will be the pancreas. We will then in July have another fireside chat focusing on questions submitted by you. We are always open to questions, so please feel free to submit them so we can continue to educate the community. And that will be
we'll determine and publish the date soon for that.
Yes, thank you, Dr. Stone. On August 23rd, I am very excited for this. We will have a fireside chat, and the subject will be vaccines and preventions of infections, and that will be Dr. Camille Cotton from Massachusetts General Hospital. And then in October, we will switch gears, and the next conversation hosted by me will be regarding a very important topic, mental health and how it relates to IgG4-RD. There will be more information coming soon regarding that.
And I'll say just a word about the upcoming fireside chats and other educational offerings. This session today is an extra one that we added in because there were so many questions that we hadn't been able to get to in previous fireside chats. So we're certainly delighted to add in another session from time to time to try to cover as many of your questions as possible. Now, I would call attention to the July fireside chat. This is going to be a roundtable of international experts. We'll have 5 or 6 experts from all over the world to answer your specific questions, bringing the absolute top expertise in all of the questions, doing our best to try to answer your questions well.
And you may have seen this week that we launched something we have been working very hard on, and that is the Foundation's Physician Network. We are so excited for the launch of this network because, as we all know, one of the biggest challenges that patients face is finding a physician within reach to access that specializes or has knowledge in IgG4 related disease. So already we on the map have 26 countries, 6 continents, and 12 specialties.
And the day after launching this, 10 additional physicians had joined. So we are committed to continuing to grow this physician network every day. Unfortunately, there's still large areas of the world that don't have an IgG4 related disease expert close. This is a major priority for the foundation.
Yes. Our next announcement is very, very exciting, and it has been hard to keep a secret. We are going to be hosting the first patient jamboree, which also will be known as the IgG4ward Jam. And that will be just outside of Washington, D.C., Tyson's Corner, McLean, Virginia. And it will be held on November 9th and 10th, which is a Saturday and Sunday. We are looking forward to this 2-day in-person event to connect patients, caregivers, physicians, allow you all to be in person, networking with one another. We will have practical talks by disease experts on subjects such as treatment symptom, mental health, more explanations in patient language regarding the disease and how to live with the disease. We'll also have breakout sessions, which will allow you all to come together in smaller groups to learn more about living with IgG4 related disease. I am very, very excited for this.
I am too. And we'll also be polling our membership about what you would like to see, the content you would like to see covered. We have a rough draft of the agenda, which we'll be publishing soon, but we'll be surveying you so that you can give your input about just what you would like to see here. We don't have the dates on the slide, but it is November 9th and 10th, as Katharine mentioned. So mark your calendars now. And you can actually find more information about this already on our website.
So now, since we just loaded you all with some very exciting announcements, we are going to switch to our questions. And I'm going to start by asking Dr. Stone, how do physicians identify flares in a person with IgG4 related disease?
This is very important. There's a lot of confusion about this, I think, in general care. And so it's great to have a conversation about this on a fireside chat. Physicians define a flare as a return of active disease. So when patients start treatment, their disease is active. Hopefully, we get patients into remission with treatment as quickly as possible. And when that disease becomes active again, then that is a flare. The disease can also flare, can certainly flare while patients are on treatment. If they're on just a little bit of steroids, the disease can flare then. But a flare is a return of active disease. And so let me just remind you, in trying to formulate an answer to this question, I came up with this figure, which is a typical disease activity pattern for a patient with IgG4 related disease. On the y-axis here, we have disease activity, zero disease activity, this would be remission, and then maximum here. And on the x-axis is time. So what happens typically in IgG4 related disease? It's a slow disease. Patients have had this disease active for months or even years very often before it is diagnosed. So they are asymptomatic for long periods of time. And then finally, the disease activity builds up enough so that it is obviously present in one or more organs. And then patients begin to have symptoms. This is realized, the diagnosis is made, and they start treatment. And then because we're actually good at getting patients into remission, after treatment, this is what the disease activity looks like. There's no disease activity. And this is our opportunity here. This is remission. And this is the opportunity that we have to seize. Patients can seize this and do everything that they can to ensure that they remain in remission. And that means being monitored. So making sure that you keep up with your doctor's appointments, that you make sure that you're keeping up with your blood work and have regular monitoring to make sure that this disease is still in remission. And we'll talk more about just how one monitors this disease. Our current therapies don't cure the disease, at least in most patients. The disease typically comes back if we follow patients long enough. So if we're following closely with regular monitoring, we see an uptick in disease. And at that point, we know to institute treatment again, but even before the patient becomes clinically symptomatic, even before there's a chance for the disease to cause any more damage. And it is important, and I emphasize this again, IgG4 related disease is a slow moving disorder. Nothing happens really fast with this disease. It builds up over many months, years, before the diagnosis can be made, before it is clinically evident. Once we have control of it, the disease does not cycle rapidly from a period of disease quiescence or remission to active disease and then back to remission again, at least not without treatment for flare. So patients really don't cycle in and out of periods of active disease. If there's the sense that they're having frequent flares, then I think it's important to ask the question, is what the patient is perceiving, is it actually disease activity, or is it something else? And Katharine has been writing a lot about the impact of mental health on disease expression. And I encourage you all to read those articles and think about them very well, because once we've begun to get the disease under control, if we're watching it carefully, we are typically able to keep it under good control. And then if it starts to become active again, then knock it back into remission with treatment. But patients don't cycle rapidly back and forth between periods of active disease and remission.
Thank you, Dr. Stone. I just have a follow-up question regarding that. So patients may not feel their best all the time, even with treatment, and that doesn't necessarily mean that they're in a flare. It just may mean that they're not feeling their best on that particular day. Is that a accurate
That's
assumption?
right. Yeah, there's a tendency when one has a diagnosis, finally, after waiting to get the correct diagnosis for a long time in so many cases, there's a tendency to attribute everything that happens to you to that diagnosis. But the fact is, the rest of life is happening to us all the time too, and people can have bad days. They can be off their game for lots of reasons. Sometimes that's related to IgG4 related disease, to active disease. Sometimes it's due to damage from previously active disease that is no longer active, but has caused damage to organs. And very often it's due to something else. And so this can be a challenge that doctors and patients have to work through together in trying to understand exactly what's going on at a specific time.
Thank you so much. So we'll move on now to the next question. How often do you monitor and which test do you to check?
Oh, yes. So key question. What do we do in clinic? What do we think about when we're trying to monitor patients? So how often? What is the optimal interval? The optimal interval really has to be based upon an individual patient's characteristics. There's not one size that fits all. But if I had to choose one size that fits all, I would choose probably 4 months. If I could have a complete set of blood work on patients, and I'll give you those specifics in just a second. If I could have regular blood test monitoring every 4 months, then I would be very confident that we would stay on top of the patient's disease activity and keep it in remission by retreating patients when we need to, or by maintaining ongoing longitudinal therapy if that's the choice that we've made. Let me give you an example. The most important biomarker in this disease, not surprisingly, is IgG4. We call it IgG4 related disease. IgG4 doesn't cause IgG4 related disease, but it is a very good biomarker for most, though not all patients. So here's an example of one of my own patients. So this is a woman with a history of IgG4 related autoimmune pancreatitis. I've been following her for about 10 years now. She was in remission back in 2018, and we were checking her labs relatively frequently and began to note that her serum IgG4 was rising. And it rose over a period of a couple of months. There you can see between May and July of 2019. And at that point, though she was still completely asymptomatic, I chose to retreat her again with B-cell depletion. And her serum IgG4 concentration began to decline then and continued to be low. And we followed her through the pandemic. It was very nice. We didn't have to retreat her during the pandemic, which would have been problematic. And then all the way up to November of 2023, her serum IgG4 remained low. It crept up again, and I knew enough about her then at that point to realize her disease is becoming active again. So I retreated her again with one dose of B-cell depletion. And her serum IgG4 concentration again fell very nicely and continues to fall now, even 6 months out after being treated with B-cell depletion. So the patient was delighted. She actually teaches me Spanish, and she wrote me a note in Spanish. Los resultados de IgG4, estimado Dr. Stone, han bajado mucho y estoy muy contenta. Dear Dr. Stone, they have declined a lot, meaning the IgG4 levels, and I am very happy. Yours truly. So that's the kind of message I love getting from patients, and it really illustrates how we can use IgG4 as a biomarker for this disease.
Wonderful. Thank you so much. What about other biomarkers? Are there any other biomarkers that you look at?
Yes, so IgG4 is not the whole story. I wish it were the whole story. It would be much easier, but and it is a very big part of the story for a very big percentage of our patients. For 80 or 90% of our patients, it's a really good biomarker. But there's some other things that we check too. So IgG4 is the most important for most patients, but I do have a significant number of patients. I was corresponding with one of them just today, in whom IgE levels have been a much better biomarker of disease activity than IgG4. I have several other patients in whom that is also true. IgG1 is also a marker that we check on a regular basis. It's usually not as useful as IgG4 or IgE, but it is sometimes, particularly I find in patients who've been treated multiple times with B-cell depletion. IgG1 can be a useful thing to follow. And then there's been a lot of discussion recently. We talked about it in Milan at the International IgG4 Related Disease Symposium about the potential role of complement in this disease. So C3 and C4 are markers that can be measured in the blood, and we also check these. In contrast to the immunoglobulins, the IgG4, which are antibodies, the complement proteins become low in periods of disease activity. So the IgG4 rises, the IgE rises, but complement proteins become low when the disease is active. So we measure all of these regularly. These are what I would measure every 4 months if I could, and I try to do that. It's also important to remember to check other things at about the same interval. Routine blood tests, these are the kinds of blood tests that your physician would do at your annual checkup. Tests of kidney function, called creatinine, tests of liver function, the AST and ALT and bilirubin, for example, and tests of pancreatic function. The lipase value can also be measured in blood, and that is an important thing to check from time to time. There are some more specific markers that should be measured occasionally. And the hemoglobin A1C value is a reflection of blood sugar control. If the pancreas has been injured, then the hemoglobin A1C rises because the blood sugar level in the blood is not controlled optimally. So this should be checked probably every 6 months or so, and particularly in patients with histories of pancreatic injury. And then there is a test that can be done on a stool sample called an elastase level. And this gives a very good indication about the degree to which the pancreas has been injured, and the degree to which the pancreas's ability to make digestive enzymes has been impaired. So this can be done at baseline, particularly in patients with a history of pancreatic problems. So these are the types of tests that I test routinely on patients in trying to keep them in remission. Finally, it's important to remember that imaging can be useful in some patients, but I think we can use imaging too much. I tend to perform a comprehensive imaging at the time we make a diagnosis with CT scans of the head and neck, particularly the eyes, the orbits, and the chest and the abdomen and pelvis, just to get a good sense of where the disease is in the patient. And then it may make sense to perform follow-up imaging in some patients at some intervals that needs to be determined by what's going on with the patient. This can be follow-up CT scans, MRIs, MRCPs, which are radiologic assessment of the bile ducts within the liver and the pancreas, and even a PET scan as well. But again, I think imaging can be used too much. Imaging doesn't tell us all of the answers, and usually we can get the answers we need with regard to disease activity from very simple blood tests. And here's a question for you, Katharine. So, what is the best way for patients to spread the word about IgG4-related disease?
This is so important. And people living with IgG4-RD can really help educate the public, educate their healthcare professionals by actively spreading awareness, fostering a more informed and supportive community. And here's how. So engaging in support groups. Those are popping up now online, especially within our community as well. And participating in those support groups really allows individuals to connect, to share their experiences, and to educate others about the complexities of the disease. This interaction really helps to create an informed community because everybody's journey with the disease is different. It looks so different in everybody. So to be able to engage in those groups, to share with each other, sharing personal stories, same idea, providing those personal stories, those personal experiences as to how their disease presented, what journey they went on to find their diagnosis will help patients, will help physicians. So again, very important. Collaborating with advocacy organizations. Right now, IgG4ward is the only patient advocacy organization out there solely dedicated to IgG4 related disease. And although there are many organizations out there, ours is dedicated to IgG4, and we will help to educate, to broaden the education around the world. So collaborating with these organizations, again, helps spread the word. Support research initiatives. This is also very important, and people living with the disease can support these by, again, educating themselves, engaging in clinical trials, finding doctors that specialize in this disease. Thank you, Dr. Stone. And now a question for you. Does IgG4-RD cause dry eyes?
Great question, and absolutely it does. So this is the drawing of the first patient recognized in medical history to have IgG4 related disease. He was a 44-year-old German farmer. This was published in the German medical literature back in 1892 by a very famous surgeon of the day named Johann Miklich. And if you notice the patient's picture, well, he's got very, very big submandibular glands and parotid glands. But the lacrimal glands, which are right here on the outer upper part of the eye, were so big that this patient could barely open his eyes. So lacrimal glands are the glands that make tears. And when these glands are affected in IgG4 related disease, patients often don't make enough tears and they have trouble with dry eye. This 44-year-old German farmer has become sort of the symbol of IgG4 related disease. And in the early days of IgG4 related disease, meaning only 12 or 15 years ago, when the world was becoming more aware of this condition, almost every talk started with a picture of this man. And indeed, his image graced the poster of our first International IgG4 related disease symposium that we held in 2011. This is, again, a drawing from Miklich's original paper. This must be Miklich's thumb. I've always been amused that the artist felt the need to draw in the examiner's thumb, but this is the lacrimal gland if the eyelid is gently everted. And this is one of my patients, and that's the lacrimal gland, and that's my thumb. So this is an abnormally enlarged lacrimal gland because of infiltration with the inflammation associated with IgG4 related disease. So IgG4 related disease can not only cause dry eyes, it can also cause dry mouth because, as you know, IgG4 related disease can affect the major salivary glands as well, the submandibular glands, the parotid glands, the sublingual glands. So these issues can be treated quite well. Patients very often respond, first of all, to systemic treatment. If they're treated with steroids or with B-cell depletion, these symptoms often respond. But there are also local topical therapies that can be helpful. Cyclosporin eye drops, one drop in each eye can be very effective at improving the tear flow. If the lacrimal glands are really so severely damaged, and of course, sometimes they're biopsied or even lacrimal glands are removed for the purposes of diagnosis, and that can leave patients with a real problem with dry eyes. Then sometimes ophthalmologists actually put little plugs in the nasolacrimal ducts, which are on the inside of the eyes, and they're the ducts through which tears drain into the nose. So if these are plugged up, that allows the tears to remain in the eye for longer, and the dry eye is not as big a problem. These measures work really well for the dry eyes in patients with IgG4 related disease. For the dry mouth, there's also therapy available. I tend to use cevimeline. It's a pill that can be taken 2 to 4 times a day, and I find this really improves the saliva production in patients who have dry mouth.
Thank you. Another very important question that comes up often, are there specific vitamins that individuals with IgG4 related disease should prioritize?
Great question. And yes, there's a very simple answer to this question. There will be more talk about this next month on June 20th, when Matthias Löhr from the Karolinska Institute in Sweden and Guy Katz from Massachusetts General Hospital in Boston will be holding a fireside chat to talk specifically about the pancreas. So they will comment on this further. We talked about this again at the 5th International Symposium on IgG4 related disease at the session on the pancreas. And the assembled panel agreed completely that what one needs to do in order to supplement vitamins, particularly in patients who've had pancreatic issues and may not be absorbing nutrients as well, because the pancreas is not making those digestive enzymes. The best solution in order to ensure enough of these vitamins and micronutrients is simply to take a multivitamin, 1 pill a day. So this is an example of my vitamin, and you can see all of the different ingredients in this vitamin, all of these different vitamins, and these one tablet includes 100% of the recommended daily allowance for all of these micronutrients. So one can really solve that problem or go a long way towards solving the problem of not getting enough vitamins by taking a multivitamin. So common question, but really very simple solution. And we may talk more about it in a few weeks at the next fireside chat as well.
Great. Thank you so much. Which organs tend to be involved in flares? Such an important question.
Yes, it is. So IgG4 related disease is a pretty predictable disease, actually, when it gets right down to it, especially when you've been able to observe a patient for a long period of time. The disease is likely to become active again at some point. And if we're not monitoring it carefully, it may become very active before we realize it. But the things to look for are signs of dysfunction in organs that have been previously involved. So if the major salivary glands have been involved, they're going to start swelling again. If the pancreas has been involved, well, one would like to get to recognize the recurrence, the flare, before patients become symptomatic, but the organ that is likely to flare is going to be the pancreas. So if an organ has been involved before, then it is most likely to be the tip-off that the disease is active again. Occasionally, a new organ sneaks in, but it's my suspicion that when there is evidence of a new organ being involved, I think that that organ was probably involved earlier too, and maybe that organ involvement was overshadowed by the other organ involvement. So the disease tends to come back as it presented the first time.
Thank you so much.
And here's a question for you, Katharine. How can I learn from patients about what it's like to live with IgG4 related disease?
Another great question. And learning about life with IgG4, like I stated before, is so important. And connection, again, I will continue to bring this up because it's key. Connecting with people living with IgG4 related disease is extremely important. And as I stated before, it's been nearly impossible up until recently. My husband, who is an IgG4 related disease patient, just met somebody for the first time in December that also has the disease. Prior to that, he had never met anybody, and he's had the disease for 4 years. Again, sharing experiences, so important. I talked about it before, and it's something I will continue to voice my opinion on because, again, we learn the best from one another. We learn the best from the people that are living with this disease day in and day out. You can, please, we value your experience. We want to hear from you. Please come on to IgG4ward.org. There is a link that you can click on and share your experience. And we would love with your, of course, if you okay it, to share your story with the community. Because again, we learn best from the people living with this disease. Dr. Stone, this has been asked often. A lot of people ask me this question. I've been asked this question often personally. What is the life expectancy for a person diagnosed with IgG4 related disease?
An understandable question. And I love getting this question from patients because I love the answer. But let me use this as an opportunity to talk about what the cornerstones of good care are in IgG4 related disease. So there are really 4 cornerstones of good care. And ultimately, these determine the impact on one's life and on life expectancy. So the first cornerstone is prompt diagnosis. And this is maybe our biggest challenge because the disease, as I've indicated earlier, is slow. It flies under the radar screen for many months. And this is where we have to get the awareness out about this disease to make the medical community more aware of this disease. So prompt diagnosis, or diagnosis as early as possible, is the most important, or it's a key cornerstone of good care. Effective treatment is the second. Careful management. Now, it's one thing to treat the disease and to get it into remission. We do that with a very high degree of reliability. But managing the patient over a longer period of time, and this is where the patient and the healthcare system, the patient and the physician and nurses have to work together to make sure that the patient has adequate longitudinal care. Once we get patients into remission, we've not cured them, and we need to be managing any complications that they may be having from damage, and we need to be monitoring for recurrence of disease activity or flare. And here is where patient involvement becomes so important. It's important for patients to learn to become advocates for themselves, to remind their doctors that they need to be getting their blood work done every 4 months. maybe even sooner, earlier or more often in some cases, reminding them that they might need a bone mineral density study to make sure that they're not suffering from osteoporosis. So it's very important for patients to become involved in their own care. So I was asked to complete these two sentences. And so the first one is, people diagnosed with IgG4 related disease can live, and here's how I complete it, full lives, largely unencumbered by this disease. That's a very good answer to give, and this is why I like getting this question. And then the life expectancy of a person with IgG4 related disease is normal. If we diagnose this promptly, if we treat it effectively, if we manage it carefully, longitudinally, over many months and years, with an excellent patient-physician relationship, then there is no reason that IgG4 related disease should shorten one's lifespan. I love telling my patients, you're going to live to see your grandchildren or your great-grandchildren. That's a wonderful answer to give.
And it is a wonderful answer to receive as well. There is a lot of misinformation out there, and I can personally say that I was scared to read on the internet that the life expectancy was 20 years when my husband was diagnosed at 40. So thank you so much for clarifying that.
It's so important along those lines, Katharine. It's so important to make sure you're getting up-to-date, reliable information. And
Yes.
our foundation wants to be the trusted source of truth for people living with IgG4 related disease. And I remember years ago meeting a patient who had been diagnosed with another disease. And the poor thing, she was an elderly woman. She had read in the Encyclopedia Britannica or someplace like that, that the life expectancy for patients with this disease was 6 months. And of course, since the Encyclopedia Britannica had been published, that had changed considerably. And so it's so important to make sure you have the up-to-date information from a reliable source. And that's what we're striving to be at IgG4ward.
Yes, thank you so much. Moving on to the next question, is remission possible for a person living with IgG4 related disease?
Oh, yes, absolutely. In fact, that is the expectation. We expect to get every patient into remission. IgG4 related disease is a very treatable disease. And we should get essentially 100% of patients into remission if we make the diagnosis early enough. So simple answer to that one.
Thank you. Are there any scientific trends with IgG4 related disease? Another question that is asked often.
Oh, yes. So there's a lot going on with regard to understanding the science of IgG4 related disease. And I think it's remarkable. I often pause to think how remarkable it is, how far we have come in understanding how this disease works, since the disease has only been recognized to be a unique disease for 15 or 20 years now. So the hottest trend in this disease now pertains to B cells, cells of the B lymphocyte lineage. And there's not just one cell, a B cell, there are actually multiple different types that are different stages of development of B cells. And all of these phases really are probably involved in this disease to one degree or another. But B lymphocytes or B cells are really critical. And they have been the target for most of the new therapies that we are developing now, and which we will hopefully have approved in the next year or two, and other things to come as well. So B cells are very critical, hot trending topic in IgG4 related disease. We've suspected that B cell depletion and targeting B cells in other ways would be an effective therapy for IgG4-related disease for a long time. This is a paper that our group published back in 2010. We treated this patient in 2009, and you can see the very, very large parotid glands. And then 1 month after treatment, his parotid glands had shrunk. We almost needed no further proof, but because to prove things for a regulatory point of view, it's taken us now a number of years down the road to get to the point where we may have an improved therapy for B-cell depletion soon. And here's another patient from our early experience. She was in our first treatment trial of rituximab. These are her submandibular glands on the day she received her first treatment. And then 6 months later, just dramatic improvement. This stain, CD19, stains a marker on B lymphocytes. This is the submandibular gland biopsy of the very first patient with IgG4-related disease whom I ever met. And so all of the brown staining areas are areas of concentration of B cells. So this slide alone indicates how important B cells must be in IgG4-related disease. And this is one of the major reasons that B cells have been the target of the therapies that we have been developing. Other hot trending ideas in IgG4-related disease. This drawing, which is now 5 years old, doesn't even have complement on it at all. So we are becoming aware of the potential importance of complement in IgG4 related disease. Guy Katz, who will be with us in a few weeks at the next Fireside Chat, has been studying complement quite a bit and has a very important paper that I hope will be published very soon. So complement is another area. Antigens, specific antigens is another area of great interest in the science of IgG4-related disease. The cellular interactions, the B cells, we believe, are doing a number of things in this disease, but they are maintaining the ongoing inflammation by presenting some type of triggering antigen. Something has triggered the disease, something has triggered the immune system. And the B cells, we think, are maintaining the disease by presenting this antigen to T cells. And these T cells then are making different products that damage tissue and cause fibrosis. The identity of the antigen, what has triggered the disease in the first place, is a source of great curiosity and a lot of investigation now in IgG4-related disease. And because of the power of the scientific techniques that we have now, I do think we're going to have some intriguing findings over the next few years about this. So B cells, complement, and antigen discovery, I think, are big areas in the science of IgG4-related disease right now. Oh, and imaging. At the International IgG4-related disease symposium in Milan in early April, just about 2 months ago now, Andreas Ramming from Germany described some very interesting research that's been going on at his center in Erlangen, Germany, with the development of new imaging agents. And we think that this may be very applicable to IgG4-related disease and imaging the fibrosis. And I hope that Dr. Ramming will be able to join us in July for our international roundtable discussion. I'll ask him to present some of his data himself. So imaging as well is another area of great interest in IgG4-related disease.
Excellent. We have a two-part question coming up right now. The first part is for you. Is it common for individuals to experience complete destruction of the pituitary gland?
Okay, well, fortunately, the answer to that, the short answer is that it's rare for patients to experience complete destruction, but the pituitary can be involved in IgG4-related disease. We know that IgG4-related disease tends to affect glands. I've shown you lacrimal, parotid, submandibular glands. The thyroid gland is a gland. The pancreas is a gland. The prostate is a gland. It can also be involved in IgG4-related disease, and so is the pituitary gland. And the pituitary is a fascinating gland. It's a fascinating organ, and I'll tell you just a little bit about it. The pituitary lies at the base of the brain. This is the pituitary gland. Obviously, this is the brain. And the pituitary is the source of a lot of different hormones that drive the function of other organs in the body. So there's the pituitary gland. And the pituitary derives its signals, gets its own direction from a part of the brain called the hypothalamus, which is this green area here. So the pituitary, as I've mentioned, stimulates other organs to produce hormones. So the pituitary makes hormones that travel through the blood and induce other organs to make other hormones. So the pituitary tells the thyroid gland to make thyroid hormone, which drives our basal metabolic rate. It tells the adrenal gland to make cortisol, which is a type of glucocorticoid or steroid. It tells the ovaries in women to make follicle stimulating hormone so that they will ovulate. It tells the testes in males to make testosterone, and it directs lactation or milk production in women who are breastfeeding. So the pituitary does a lot of important things, and there are other things on the list that not on the list that it does as well. This hormone production is very tightly regulated. So the signals come from the hypothalamus in the brain. They travel to the pituitary gland, and then the pituitary makes these different hormones which travel through the blood to their target organ. In this case, in this picture, the adrenal gland, which sit right on top of the kidneys and make cortisol, a steroid that is important for normal living. The hormone production is very tightly regulated. So if the cortisol level is high, there are negative feedback level loops to the hypothalamus and the pituitary, telling it to stop producing ACTH so that the adrenal gland will stop making cortisol. And if the cortisol is low, conversely, the signals from the pituitary come to increase cortisol production. Unfortunately, IgG4-related disease can affect the pituitary, infiltrating the gland, just as it does all of the other glands that were on that list. And over time, that can cause severe glandular dysfunction, and it can disrupt all of these hormone pathways. So here is a patient of mine who had IgG4-related disease for many years, multiple organs involved. And I never suspected that his pituitary gland was also involved until he had had 2 or 3 disease flares heralded by rising serum IgG4 concentrations. The patient felt well, but he lived a long way from Massachusetts, so we didn't see him that often. And over time, that subclinical disease damaged his pituitary greatly. Now, it's possible to treat pituitary failure by replacing these hormones, but that's a difficult balance to try to re-achieve. So it's not an optimal outcome. We would like to prevent this from the start so that we don't have to play catch up by figuring out how to rebalance the patient's normal hormone levels. Fortunately, if we make this diagnosis early enough, this does respond nicely to treatment. This is a case that we published in the New England Journal of Medicine a number of years ago. A patient with IgG4-related disease who presented with only pituitary involvement. He was diagnosed by a biopsy of the pituitary, not an easy thing to do, but he had biopsy confirmation of the diagnosis, and he responded with a complete remission and complete recovery of his pituitary gland. So pituitary involvement is relatively unusual, although it's probably present more often than we recognize. It is treatable, but it can be a bad outcome of the disease when it happens. So part two of the question, Katharine, is are there opportunities for individuals with a destroyed pituitary gland to connect with others who share similar experiences?
And the short answer is yes. And thank you for the individual who submitted this question, because again, another very important question. And for individuals who have a destroyed pituitary gland or other problems that have developed due to IgG4-RD, finding support and connecting with others who share similar experience, again, here I go, is crucial. And we are so excited to announce that we're launching a peer mentoring program soon, and more information will be forthcoming in the future regarding this program. But it's going to be an opportunity for individuals like this person to connect one-on-one with mentors who have firsthand experience of living with a destroyed pituitary gland or living with one kidney because they had to have their kidney removed due to damage caused by IgG4 related disease. It will offer guidance, support, a listening ear, something I know all the patients are really looking for. So we are, again, so excited, and more information will be coming soon regards to that. As well as the online community right now that is available, that's open. It's a beautiful place for individuals to come together, to share experiences, to connect, to say, hey, I've got this problem. Do you have it as well? So please come join the online community if you have not already.
And let me underscore that. So the online community, the physician network, the peer mentoring program, the IgG4ward Jam, which will happen in November, all of these are part of the Foundation's overall growing program to try to address the many needs of people living with IgG4 related disease.
All right, back to you, Dr. Stone. What is the current state of research on pediatric IgG4 related disease since 2016 academic review?
So there was a well-known paper published in 2016 in the Journal of Pediatrics describing a handful of patients with IgG4 related disease. Clearly, the disease occurs in children. It is less common than it is in adults, and I think pediatricians are not as aware of it still as they need to be, but there is growing awareness. And I have just one really key message about this. These are images of a 16-year-old boy whom I evaluated several years ago. You can see the lacrimal gland enlargement here and the inflammation here. And this young boy had been thought to have cancer because he had swollen submandibular glands here and here. It was thought that these were lymph nodes and that he must have a lymphoma. And one of these glands was removed, as you can see. And this patient had disease, multi-organ disease. He was probably the most classic patient with IgG4 related disease whom I have ever seen. And I think the message is that the disease in kids is really very much like the disease in adults. There's some sense that maybe kids are more likely to have orbital disease of the area around the eyes. But this patient and others whom I've seen illustrate the disease in kids is really very much like the disease in adults. And we will definitely be seeing some more publications about pediatric IgG4 related disease in the future.
Thank
A
you.
question for you, Katharine. How can we as patients support caregivers?
As I had to develop the answer to this question, I had to really reflect on my own personal journey as a caregiver and how I've been supported and what has helped for me and what I think will help other caregivers in the same position as me. Caregivers are essential, as we know, in the lives of individuals living with IgG4 related disease. And day in, day out, we're caring for our loved ones. We may be caring for other family members as well, including our loved one with IgG4 related disease. So it's really, really important to have open communication, foster honest dialogue, to share concerns, to share needs, strengthen understanding and collaboration between the caregivers and their loved one that they're caring for is so important. Expressing gratitude, just saying thank you will go a long way. Caregivers dedicate a lot of their lives to taking care of their loved one. So just recognizing that and offering that gratitude every now and then, I can personally say it goes a long, long way. Educate each other, work together to learn about the disease, provide resources of mutual understanding. Oftentimes my husband and I are going back and forth, sharing new information that we're finding. And it really, really helps to really have that same knowledge. And encourage self-care. Not always easy when we're caring for somebody else, but what do they say when we get on that airplane? We have to put our oxygen on first, or else we can't help our loved one. So please make sure that you're finding time to take care of yourself. Prioritize some well-being, take a break, go on a night vacation for yourself, whatever it may be. Just make sure that you're prioritizing some time. And that includes setting boundaries, establishing realistic limits, helps prevent burnout, and maintain a healthy balance between caregiving and your personal life. So a boundary that I have that my husband really respects is that I have time where I go and take care of myself. I have an hour a day that's just for me, and dedicated to me. So that has been really helpful for me to be able to take care of my husband and our 3 children. Seek external support when needed. Again, so important. I would not be able to do what I'm doing without my support network. This could include friends, family, support groups, counseling services. Again, another area that we are trying to support through IgG4ward is supporting caregivers in the online community. We have a group just dedicated to caregivers. So please come on and join caregivers if you haven't already, because this isn't always easy, and we need to really be together. Thank you, Dr. Stone.
Thank you, Katharine. Before we go to the next question, I forgot to tell the audience about how this young patient has done. And it's very important to give the longitudinal follow-up. This is what he looked like at age 16. I was very touched by this because I have a son who was 16 at the same time. And I'm so pleased to say that this boy, now man, is 24 and is in complete remission. Responded beautifully to B cell depletion, which I give him intermittently, and he is living his life fully employed. He will live to see his grandchildren and great-grandchildren, and he and his mother and I are still making sure that he has his regular appointments with me.
Excellent.
Important to get the longitudinal follow-up in this disease.
Absolutely. Especially in a case like that with a young person. Thank you. Next question. About how long can you be on a low dose of steroids before
So
they're alarmed?
steroids, yes, another a favorite topic of mine. Steroids have been around now for 75 years as the cornerstone of treatment for so many inflammatory diseases. And really the answer to the question, how long can patients be on steroids without even less than 5 milligrams a day without having an effect is, well, there is no safe dose of steroids. Steroids are very important for controlling inflammation quickly. There's nothing that controls inflammation more quickly than steroids, but there's also no safe steroid dose. So there are subclinical effects of steroids on bone and risk of infection and glucose metabolism and cataract formation. And so there's really no safe dose. The mission, one of the main missions of the foundation and the IgG4 related disease community over the next few years is to develop agents that allow us to minimize and hopefully eliminate altogether the need for using steroids to treat IgG4-related disease. And there is more information about that now on our website, or will be very shortly. We have two new videos. Each is 7 or 8 minutes long. And if you have been on steroids before or just starting steroids, still on steroids, these videos might be good for you to review. One is called The Good and Bad of Glucocorticoids, and the other is called Glucocorticoids, a Double-Edged Sword. So those should be available by next week at the latest on our website under resources. So have a look.
And I can personally say those videos are very helpful in understanding. My husband has been on steroids. We've seen the impact of them, and watching those videos was really beneficial and helpful. Thank you.
And there'll be more related to research on steroids coming up on our website soon, and more conversation about that on our online community. So stay tuned for that. A question for you, Kat. How can IgG4ward help improve access for patients with IgG4-related disease who see physicians who specialize in their disease?
Yes, great question. And here's our image again about the Physicians Network. We are dedicated. IgG4ward is dedicated to improving access to care for patients with IgG4-related disease. We heard Dr. Stone say how important it is for early diagnosis, for follow-up. We need people who specialize in this disease, who are aware of some of the things Dr. Stone mentioned previously in our talk. So this is how we are going to try to provide this important resource through the Physicians Network, allowing people to go onto our website, search their area, whether it be in the United States, in Europe, and try to find a physician. It's very, very important.
And I would emphasize that you can help us expand the network too. If you know a great doctor out there who is a wonderful clinician, a sensitive doctor, please let us know who that physician is. We would love to have her or him in our network. You can send us whatever you know about that physician, their name, their town or city, their clinic or their hospital. If you have an email address, that is obviously easiest, but that's not always possible to find. Just feel free to make suggestions to us about physicians who should be in our network. We want to cover the globe with experts on this disease. Another question for you, Kat. How can we all learn to live our lives with less anxiety and more optimism?
Great question. And I think everyone can benefit from the answer of this question, because in today's world, we're often surrounded and inundated with negativity, whether it's from news headlines, from social media, or our personal challenges. And then we add a complex disease like IgG4-RD to that, and it intensifies feelings, and it makes it difficult to shake that negativity day to day. So first, we need to it's not something that comes naturally. It takes practice, it takes patience, and it takes self-awareness. I underlined practice because it truly is a practice each and every day to shift your mindset, practicing mindfulness, cultivating self-awareness. That's how you can gradually learn to, navigate your day with more positivity and less negativity. Really consciously focusing on the present moment. Not always easy, but pausing and trying to find something within that moment that is positive. It might just be the sun shining. It might be, a flower blooming, but just finding that one. As an IgG4 related disease patient, Mitchell has stated little win. If we can find those little wins in life, it can really help us with finding more positivity and shaking off some of that negativity. But personally, it is difficult for me as well. And it is something that takes practice and being self-aware of your triggers, of something that, hey, this doesn't feel right within my body. What can I do to change it? So all of those things really are so important. And I am going to be offering some more guidance around this area in future blog posts for the foundation. So stay tuned.
Thank you, Kat.
You're welcome. The next question's for you. Is it safe to remain on rituximab for extended periods?
So yes, the short answer is it is safe to stay stay on rituximab generally for long periods of time. There are many patients with lymphoma who get rituximab intermittently for long periods of time. But that yes also has a but. And the COVID pandemic really made us aware of the potential downsides of continued uninterrupted B cell depletion and the challenges for the management of IgG4 related disease that poses. So that but relates to vaccines, vaccination, COVID, and other infections. And everybody in the medical community has become more aware of this. And because of the importance of B cell depletion for IgG4 related disease, patients with IgG4 related disease really need to have a good handle on this. So the vaccines that are critical to think about, and we're going to be talking more about this in August before viral season begins, are COVID, the flu vaccine, the shingles vaccine, the pneumovax, the pneumonia vaccine, and RSV. So there are really 5 major kinds of vaccines that patients and their physicians need to think about. Vaccines are really critical for patients with IgG4 related disease. We learned very painfully in the COVID pandemic that patients, regardless of what their underlying diagnosis is, don't respond well to vaccines if they have been treated with B cell depletion. So there's a very important choreography that needs to happen, a timing of administration of vaccine before administration of B cell depletion therapy or steroids. Steroids also have an important negative impact on vaccination. So the timing of vaccination requires careful planning, and it's really optimal to give the vaccines 3 to 4 weeks before starting treatment whenever possible. Now, if a patient is really, really sick and treatment needs to begin immediately, then treatment needs to begin immediately. But very often with IgG4 related disease, which is a slow disease, we are able to administer treatment, start therapy on an elective basis and get these vaccines done first. Whenever we can do that, it's optimal to manage the disease that way. It's important to remember that the effects of B cell depletion last many months. If you just got rituximab 3 weeks ago, you're not going to be able to make good responses to vaccines for many months, probably 6 months at least. That's why it's really important to make sure that you're up to date on vaccinations before you might need to be treated again. Vaccines work, and we know this from the stories of polio. This is the dime. Franklin Delano Roosevelt, who himself was crippled by polio as an adult, shown on the dime with Jonas Salk, who made the first polio vaccine. We don't see kids walking around with braces anymore because of polio. And that's because the polio vaccine campaign was so effective. Similarly, we don't see cases of smallpox anymore. That disease has been eradicated. This is not even a real picture of smallpox. It was a computer-generated picture because there are no cases of smallpox in the world today. It's been eliminated because of an effective worldwide vaccine campaign. So vaccines work, and patients with IgG4 related disease need to work with their physicians to make sure that they are adequately vaccinated. This is so important. We get questions about this all the time. So we are planning a special fireside chat this summer, late summer, before virus season. So on August 23rd, Dr. Camille Cotton, who is an infectious disease expert at Massachusetts General Hospital, dedicates her career to the treatment and management of patients with immune deficiencies. We'll talk about vaccines, immunity, COVID, and other infections. And as always, we'll invite you to submit your questions in advance. That's going to be a great discussion. So I hope you'll all tune in. Kat, the question is, what are 2 everyday tips that can help people living with IgG4 related disease?
This was a tough one to only choose 2, but if I can only choose 2, the first one, and as the quote says, be gentle with yourself because you truly are doing the best that you can. And all of you that are living with this rare, complex disease, you have all been on a long journey to diagnosis. You all are managing your symptoms to the best of your ability, managing your treatment, figuring out what is the best treatment. That is a lot. That is a lot to deal with on a daily basis. So please be gentle with yourself. Talk to yourself in a positive way, the way that you would talk to somebody else living with this disease. I hear often a lot of you all are very hard on yourself, hard on, having to rest all the time, not being able to complete some of your responsibilities. And please be gentle with yourself, because if there was somebody right next to you that was dealing with the same issue, I'm pretty sure that you would give them, a pat on the back and saying you're doing the best that you can. The second tip is listen to your body. You are your body's expert. And if you feel something not right within yourself, call your physician, bring it up, ask a question. Is this normal? Like Dr. Stone said earlier, not everything is related to IgG4 related disease. So be aware of that. Whether it's a mental health symptom, whether it's a physical symptom, just listen to your body. So those are the 2 tips. It was really hard to bring them down to just 2, but I hope that's helpful.
Well chosen, though. Thank you,
Thank
Katharine.
you. Question for you, Dr. Stone. If my blood work looks normal 6+ months after my first round of rituximab, is it responsible to stop and check blood every 4 months or so?
Absolutely, yes. This gets back to the importance of monitoring. If you're having your blood work checked regularly and you've seen a nice decline in your serum IgG4 concentrations and you appear to be in remission with regard to symptoms, then absolutely, it is very reasonable to get off prednisone, to give yourself a pause in consultation with your physician from B-cell depletion or other therapy. It is absolutely fine. It's advisable to do that, I think, for many reasons, to allow timely administration of vaccines. So yes, that is perfectly acceptable. It's nice to declare victory. You've achieved remission. You've got to be monitored regularly, but it is fine to think about stopping therapy at that point.
Excellent. IgG4 level is 700 to 1,000, yet no apparent symptoms. What could that indicate?
So this is sort of the opposite of the previous question, where the serum IgG4 concentrations were normal. Here, the serum concentrations are high. They're very high, but the patient is not symptomatic. That is very characteristic of IgG4 related disease. To me, that indicates that there is probably subclinical disease going on somewhere. When the serum IgG4 concentration is rising, I have learned in 17 years of taking care of patients with this disease, that means that the disease is active somewhere in the body. So I love this picture because it really captures the immunology of this disease so well. This is a lung biopsy from a patient with IgG4 related disease, and the normal lung tissue is out here. But this is a lymphoid aggregate, and all of these areas here are germinal centers, and it's just outside these areas where IgG4 is made. So the patient probably has no symptoms at all, but the patient has lymphoid aggregates in organs that are involved, and those lymphoid aggregates are pumping out IgG4 molecules, which are getting into the bloodstream and they're rising. And that means that the disease is active. Fortunately, the patient is asymptomatic, and it's a wonderful time to think about reinitiating treatment before the patient becomes symptomatic and before important organs are damaged. So I would worry very much about subclinical disease in a patient who has a very elevated serum IgG4 concentration.
Do untreated flares ever go into remission?
Common question. And the answer is very rarely, very rarely. Once this disease gets active, once those lymphoid aggregates are pumping out IgG4 reflecting active disease, it very seldom turns around and goes back into hibernation. In patients with very limited disease expression, maybe just mild enlargement of the submandibular glands, it may seem to go into hibernation for a while, but it's typically only for a little while. And I would not bet on it. If there is active disease, it probably needs to be treated. And the wise thing is to treat it as quickly and as effectively and as safely as possible, and then to monitor for a return. I would not hope for a miracle that it's just going to go away by itself. And I worry essentially about subclinical disease activity in that setting.
Thank you. So important. Do any of the commonly used pain relievers pose a problem for patients with IgG4 related disease?
So this is a great bread and butter internal medicine question about the use of things like acetaminophen or Tylenol and non-steroidal anti-inflammatory drugs that we often have to take, whether we've got IgG4 related disease or not. They're very commonly used medications, and the rest of life happens to patients with IgG4 related disease while they have it. They may get a headache that's not related to IgG4 related disease. So they need to think about how to use these medications. So with regard to acetaminophen or Tylenol, it's important really never for any patient to take more than 2 grams a day of this. So this amounts to 4 extra strength Tylenol tablets. One shouldn't take more than 4 extra strength Tylenol tablets in one day. And particular caution is needed for patients with histories of liver or kidney damage, as unfortunately some patients with IgG4 related disease have. So these medications can and should be used appropriately, but appropriate caution is also necessary. And the same is true for non-steroidal anti-inflammatory drugs. Very important. When you get the flu or something like that, these medications can really help you feel better. But if you've got high blood pressure at baseline, if you've got reduced kidney function at baseline, then you need to be careful about taking these drugs. In particular, Tylenol might be a better choice. I also worry about taking too much non-steroidal anti-inflammatory drug, or NSAIDs as they're called sometimes. They can induce ulcers in the stomach or the duodenum, the small intestine. And one has to be particularly careful if you're taking an anticoagulant. If you're on warfarin or Coumadin, then non-steroidal anti-inflammatory drugs are probably contraindicated. You probably shouldn't take them. And check with your doctor before doing that. Katharine, here's one for you. How do we as patients bring our doctors up to speed on IgG4 related disease?
Well, one of the first ways you can do it is please refer your provider to our website, www.IgG4ward.org, where we, like Dr. Stone said in the beginning, it's the #1 trusted area with true information regarding the disease, unlike that information that I found when my husband was first diagnosed. Please refer them to the website. Suggest that they join the IgG4ward's Foundation's physician network, this is a great opportunity for them to also join the online community where there is a private group for physicians to bounce ideas off of one another as well. Very important. And we will be offering coming soon a downloadable and printable PDF for patients to give to their doctors to bring to their appointments, which will have very important information regarding IgG4 related disease.
And I think this was our last question that we're going to be able to address in this fireside chat. We wanted to close with just a couple of reminders, though.
Yes, please. As we were so happy to announce earlier, please remember we are going to be doing the IgG4ward Jam in November 9th and 10th. There will be a survey following the close of this, and as well as a link on our website where you can access details and let us know if you would like to be involved in this wonderful, exciting opportunity.
And follow the website for upcoming educational program related to the pancreas, specifically on June 20th. Then an international panel of experts to address your questions in July. And then finally, a conversation with an infectious disease expert, Camille Cotton, in late August. Thanks so much for joining us today. And then we have one final slide, I think.
Yes, we were, this comment was submitted to us and we created a little visual to go along with it. With sincere thanks to everyone involved in IgG4ward, it feels as if I've been thrown a life belt in a sea of uncertainty. Thank you. And I am so grateful that you feel that way, because that is exactly how the kind of support we want to provide to the people living with IgG4 related disease. Thank you all for joining us.